তাহলে আমি কিভাবে যাব?
এই যে আশরাফ ফেসবুক দেখাচ্ছে তো, লাইভ অন ফেসবুক।
হ্যাঁ একটু কি ফেসবুক পেজে কেউ যাবেন প্লিজ, BSCRS এর পেজে।
BSCRS পেজ আমার কাছে নেই।
Bangladesh Society of Cataract and Refractive Surgeons.
It's live.
It's live now?
Yes.
Okay, we are live now.
Nozrul sir, can we start?
Oh, sure. মাহবুব কোথায়?
এই চলে আসছে।
আচ্ছা, যদি মাহবুব অপেক্ষা করতে 1 মিনিট অপেক্ষা করতে পারি কিনা? মাহবুব জয়েন করলেই আমরা শুরু করি।
হ্যাঁ, আমি জয়েন করেছি। থ্যাংক ইউ। আসসালামু আলাইকুম।
আসসালামু আলাইকুম স্যার।
আসসালামু আলাইকুম স্যার।
Okay, I think we can start, please.
BSCRS.
My screen visible?
Yes.
Good evening, everyone. Welcome to Mentor-Mentee Interactive Cataract Webinar, which is organized by Bangladesh Society of Cataract and Refractive Surgeons. I must thank the President of BSCRS, Professor Nozrul Islam, Secretary General Dr. Shaukat Kabir, and Chairman of the Scientific Committee, Dr. Mahbubur Rahman Chaudhry, for such a wonderful achievement. Why am I saying? Because this webinar is completely different from the others. Why is this? Over here, we have some young skilled surgeons who are expert at their fields. So they're going to share how they started, how they overcame their fears. And also we are grateful and we are honored to have with us our teachers, the skilled surgeons who are going to share their experience and who are going to help us to go ahead with our surgeries. Thank you everyone for joining. At first, I will share today's speakers. We have Professor Jalal Ahmed sir with us. He's the former president of Bangladesh Society of Cataract and Refractive Surgeons and director professor of Bangladesh Eye Hospital and Institute. We have Dr. Mahbubur Rahman Chaudhry, who's the chairman of Bangladesh Eye Hospital and Institute and its branches, former president of Bangladesh Society of Cataract and Refractive Surgeons, and chairman of Scientific Committee of BSCRS. We are happy to have with us Professor M. Nozrul Islam, President of Bangladesh Society of Cataract and Refractive Surgeons and consultant glaucoma and phacosurgeon, Bangladesh Eye Hospital and Institute. We also have with us Dr. Mohammad Shaukat Kabir, Secretary General, Bangladesh Society of Cataract and Refractive Surgeons and Associate Professor of Ophthalmology of Bangabandhu Sheikh Mujib Medical University. We have with us Dr. Ishtiaq Anwar, Joint Secretary of Bangladesh Society of Cataract and Refractive Surgeon, Consultant Glaucoma and Cataract and Refractive Surgeon, Bangladesh Eye Hospital and Institute. Dr. Zakia Wadud has joined us. She is the Consultant Glaucoma and Phacosurgeon, Bangladesh Eye Hospital and Institute, former Head of Glaucoma of Lions Eye Institute and Hospital. Dr. Ashraful Haq is here. He is the Office Secretary of Bangladesh Society of Cataract and Refractive Surgeon, Consultant Refractive Surgeon of Bangladesh Eye Hospital and Institute. Dr. Shams Mohammad Noman, Senior Consultant and Head of Glaucoma, Chittagong Eye Infirmary and Training Complex, and also General Secretary of OSB, Chattogram. Dr. Sarawat Rahman, Consultant Neuro-Ophthalmologist and Cataract and Refractive Surgeon of Bangladesh Eye Hospital and Institute. Dr. Muntakim Shohid, Assistant Professor, Consultant and Head of Cataract Department, Ispahani Islamia Eye Institute and Hospital. And I am Dr. Mahbubur Rahman Chaudhry, Scientific Secretary of Bangladesh Society of Cataract and Refractive Surgeon. So without further ado, we will start our webinar because we are all looking forward to it. And I must say, anyone, if you have any question, please write in the question answer or chat box and we will answer it. And I will request Professor Nozrul Islam to give his welcome speech. Sir, can you please unmute?
Yes. Thank you, Majiba. Assalamu alaikum, everybody. Actually, virtual platform has been the great platform now for the education. And throughout the world, many societies are actually working on virtually in this platform. BSCRS started its virtual meeting from the very beginning of lockdown. We did some webinar on the protocols during the new normal life, especially in the outdoor patients management and operation theater management. After that, unfortunately, we lost our Joint Secretary, Dr. Jahangirullah Mukut, and there was a big gap. And after that, after some time, again, we started our webinar, especially with the Bangladesh Eye Hospital. We had two great webinars with Bangladesh Eye Hospital. And for that, I'd like to thank the chairman, MD, and others, especially Dr. Ashraf, for this opportunity to the BSCRS. Today's webinar, as Dr. Maziba said, is really special because it is the webinar or mentor-mentees. And really, I feel very happy when I see that my students, my junior colleagues can do a better surgery than me. And I think that is the success of a teacher, of a mentor. At the outset, I like to thank all the executive committee members of BSCRS for this support, especially our advisor, Dr. Mahbub Chaudhuri, Professor Jalal Ahmed, Secretary General, Dr. Shaukat Kabir, Treasurer, Dr. Harun Rashid, and all others. I am really happy to the scientific committee of BSCRS because its chairman, Dr. Mahbub Chaudhuri, Secretary, Dr. Mahajibur Rahman Chaudhuri, for their continuous support and dynamic effort they are giving to the scientific works in this society. Finally, I hope tonight's webinar will be truly educational and our members will be benefited from this webinar and they will enjoy the webinar. Thank you very much. I hope the mentor-mentee is going to be very enjoyable and very educative webinar tonight. Thank you very much.
Thank you, sir. So we will get started. Our first speaker is Dr. Zakia Wadud. Ma'am, please share your screen, and she will be talking about how she started her toric journey. Dr. Zakia, please share your screen.
Am I visible?
Yes.
Assalamu alaikum, everyone. Welcome to my presentation. I'll be talking on how I started my journey with toric implantation. So in 18th August 2016, Selina Nasrin, a 64 years old lady, came to me with the complaints of dimness of vision in her right eye. She was diabetic, and on examination, these were her findings. The best corrected visual acuity in her right eye was 660 with minus 4.5 diopter spherical and minus 1.5 diopter cylinder at 35-degree axis. And in left eye, it was 6.9 with minus 2 diopter spherical and minus 2.5 diopter cylinder at 130 axis. So she had nuclear sclerosis grade 3 and cortical cataract along with posterior subcapsular cataract in her right eye and nuclear sclerosis grade 2 in her left eye. All her other anterosegmented posterior segment findings were within normal limit. So the diagnosis was cataract in both eyes, right eye more than the left eye. So with that diagnosis, we planned for cataract surgery in her right eye. And the biometry report was as follows. The K1 reading was 44.75 at 15 degree, and the K2 was 46.75 at 105 degree. So there was a 2 diopter difference between the K readings. So I advised for phaco with PCIOL with accuracy of IQ. She asked me for the best possible IOL implantation, and at that point in time, IQ-less IOL was one of the best IOL options that I had in mind. So after 1 month of surgery, the refraction was 6.6 with minus 1.5 diopter cylinder at 30 degree. It was a pity that she still had to wear her glasses even despite nice surgery and with a very good IOL. So at this point in time, I will just share the roadmap of my career. So after completing my post-graduation in 2007, I started my career as an ophthalmologist at Islami Eye Hospital, followed by small incision cataract surgery in 2009. Then I did start my phaco in 2010, and at the same time I did my glaucoma fellowship. In 2016, I participated in phaco development program jointly organized by Bangladesh Eye Hospital and Alcon, Bangladesh. And as part of that phaco development program, I participated in the astigmatism management program in 2019. So 3 years later, on 14th January 2020, the same patient came to me with a complaint of dimness of vision in her left eye. And she was seen to have grade 3 nuclear sclerosis and posterior subcapsular cataract in that eye. So this is her biometry reading. The K1 was 44.75 at 160 degree, and K2 was 47.75 at 70 degree. So there's a difference of 3 diopter between the K readings. We recheck the IOL with the IOL master, biometry with the IOL master. And this was the, I planned for toric IOL implantation this time and calculated the IOL power with the online APRS's online direct toric calculator. And the recommended IOL power was 15 diopter with the model of SN685 at an axis of placement 69. So this time I advised for phaco with BCIOL with accuracy toric IOL in her left eye. 1 month after surgery, the refraction was 6 bars unaided and 6.6 with minus 0.50 diopter cylinder at 135 degree. So in retrospect, what were the barriers that prevented me from advising the toric IOL implantation in her right eye, which the first time that I did the surgery on her? So I would say it was lack of awareness and to some extent knowledge about the impact of toric IOL on management of astigmatism. And I think I was focused more on being a glaucoma specialist, preserving the central island of vision rather than looking at the cataract surgery part of my practice. And there's also this natural inhibitory tendency that we have to leave our comfort zone and venture out into the unknown territory. So what are the additional efforts that we need to go for switching from monofocal to toric? I would say that not much, not many. So this is one of my recommendations, that we should not be offering any type of IOL before seeing the biometry report. We should take time to scrutinize the biometry meticulously and also counsel the patient. So we can start by practicing the marking on our regular phaco patients. And during our regular phaco surgery, we can practice the elaborate washout of viscoelastics, particularly from behind the IOL. And last but not the least is we should not hesitate to ask for help from the experts. So when my patient asked me this question after doing the surgery in her left eye, that could you have used the same IOL in the other eye, because she didn't need any spectacle in this eye. So I feel that our patients are not ophthalmologists. They do not know the difference between monofocal, toric, or multifocal. These differences. It is our responsibility as ophthalmologists to offer them the best possible solution or best possible there is to offer and help them to make the decision. So thank you everyone for your patient hearing.
Thank you, Dr. Zakia. That was a wonderful presentation. And I hope that you can inspire the young surgeons out there to start toric. I would like to request Professor Jalal Ahmed sir to give his expert opinion on Dr. Zakia's presentation. And then, sir, will you please share your screen? Sir, can you unmute yourself, sir?
We are all, thank you, Dr. Maziba, for your nice moderation. And really, we all are happy seeing the ladder pattern rise of Professor Zakia Wadud's performance. from glaucoma surgeon to cataract surgeon, from cataract surgeon to refractive cataract surgeon, from his patient who was not really very happy, our patient is now very happy. So again, if we go an overview of this toric IOL surgery, I want to share my screen. Is it visible?
Yes, sir.
Whether visible?
Yes.
Okay. Thank you very. I am thankful to Cataract Society, especially the president and chairman scientific committee for and the secretary for inviting us to join this wonderful meeting. Continuing Dr. Jakia's presentation, we can again have a review. So if you consider that who are the candidates for toric IOL surgery, the patient who has regular corneal astigmatism more than 1 diopter of cylindrical power, they are the good candidate for toric IOL surgery. How to detect the toricity of that patient, and how to convince or counsel the patient or their guardians, and benefit and exemplary demonstrations. I want to show one of my video that is recorded just a few hours back, how I practically do in my chamber. So I want to sound is very low. Please listen to that what I do.
Sir, it is not audible. Can you share what you are doing, sir?
There is no sound. Can you just tell us what you are doing?
Oh, sound? No sound?
Yes, sir. There is no sound. Can you just go along with the video?
You can talk along with the video. You can talk. You can talk along with the video. You see the video and you can talk what you're doing. Okay.
Oh. কিন্তু আমি তো বুঝতে পারতেন না। No sound is audible?
না স্যার, আপনি যদি বলেন আমাদের কি করতে কাউন্সেলিংটা স্যার।
আচ্ছা, কাউন্সেলিংটা আমি যেটা করলাম সেটা পেশেন্ট, আজকেরই পেশেন্টের 70 ইয়ার্স মেল, তার সাথে ছিল তার মেয়ে। তো আমি তার বললাম ক্যাটারাক্ট সে করতে আসছে, বললো যে আমরা ক্যাটারাক্ট করতে চাই। তো আমি বায়োমেট্রি করে আনলাম। বায়োমেট্রি করে আনার পরে বায়োমেট্রিটা তাকে দেখাইলাম, যে ভিডিওতে দেখছেন যে বায়োমেট্রি দেখাইলাম যে এই যে বায়োমেট্রি রিডিং, এখানে K1 এবং K2 বাম চোখে ডিফারেন্স হলো 1, আর ডান চোখে বাম চোখে ডিফারেন্স হলো 0.58, আর ডান চোখে হলো 0.58, বাম চোখে হলো 1.44। আমি বললাম যে এই যে K1 K2 ডিফারেন্স এখানে লেখা আছে 1.44, এই পাওয়ারটা হলো সিলিন্ড্রিক্যাল পাওয়ার। আমরা যদি এই স্পেরিক্যাল লেন্স দিই তাহলে স্পেরিক্যাল কারেকশন হয়, সিলিন্ড্রিক্যাল পাওয়ার কারেকশন হয় না। তারপরে আমি তাকে ওই ট্রায়াল বক্সের 2টা লেন্স হাতে দিলাম, যে তুমি এটা, মেয়েটা স্টুডেন্ট, তোর আমি হাতে দিলাম, দিয়ে আমার মাইক্রোস্কোপ স্লিট ল্যাম্পের একটা নবের দিকে ওর তাকাইতে বললাম। তা 2টা লেন্সও হাতে নিল, দেখছেন যে একটা +3 স্পেরিক্যাল আর একটা +3 সিলিন্ডার। আমি এখন +3 স্পেরিক্যাল দিয়ে ওর ওই স্লিট ল্যাম্পের নবটার দিকে উপরে নিচে দিলাম, ডাইনে বামে দিলাম, বলে তুমি এখন দেখো ওই ছবিটা কি হয়, উপরেও যায় নিচেও যায়। এটা উপরে নিলে ইমেজটা নিচে যায়, এটা নিচে নিলে ইমেজটা উপরে যায়, ডাইনে নিলে বামে যায়, বামে নিলে ডাইনে যায়। আর যখন সিলিন্ড্রিক্যাল 3 লেন্সটা দিলাম তখন বললাম যে, তখন দেখলাম যে হরাইজন্টালি যখন মুভ করে, যে ডাইন বামে মুভ করলে এটা কোনো ইমেজটা আর মুভ করে না, উপরে নিচে যখন মুভ করে ও ছবি দেখে ও বললো যে জি স্যার। ও যখন এটা দেখে তারপরে বললাম যে তোমার বাবার জন্য এই যে ডিফারেন্সটা, এই লেন্সের কারেকশন যে লেন্সে দেয় সেই লেন্সের নাম টরিক লেন্স। তোমার বাবার বাম চোখে টরিক লেন্স যদি না দাও, নন টরিকও দিতে পারো, কিন্তু তাহলে যে দৃষ্টি আসবে সে দৃষ্টিটা স্বচ্ছ দৃষ্টি না, সে দৃষ্টিটার মধ্যে কোয়ালিটি কম থাকবে। আর যদি তুমি টরিক লেন্স দাও তাহলে টরিকের দৃষ্টিটা হবে একেবারে স্বচ্ছ দৃষ্টি, এবং সেটা তোমার বাবার জন্য মোস্ট অ্যাপ্রোপ্রিয়েট। এটা বললাম, পরে এটা আজকে ঠিক করে গেছে যে করবে টরিক, এবং এটা আমি ওই 3 তারিখের জন্য অলরেডি রেখে দিছি। এটা কিন্তু আমি ভয়েসটা কেন হইলো না আমি ঠিক জানি না। নেক্সট আচ্ছা, নাও উই গো টু দ্য প্রিন্ট। এই যে যেটা দেখাইছিলাম, যে আরেকটা জিনিস আমি শেয়ার করতে চাই, আমি বাংলায় বলছি এই জন্য যে দেখেন আমাদের
there are some few foreigners, sir, so it would be better.
Also, here is a few print. Middle one is the contact biometry, and left and right one. Left one is the biometry in IOL Master 700, but it is in SRK-T formula, and right one is biometry in IOL Master 700, but also in Barrett toric formula. But what I want to show that in contact biometry, even in contact biometry, the power, spherical power is 23.50, and both IOL Master 700 in SRK-T and Barrett toric, all these three are 23. You can see in the red mark that the power is 23.50. So 3, if you can, even if you cannot afford the IOL Master, or in your center there is no higher grade biometry machine, but even with immersion machine, we can do the biometry with exactly near to the same result as the advanced biometry machine. So not to be worried that I have no IOL Master machine, I cannot do toric lens. So even you see that in our Bangladesh Eye Hospital, the technicians are so expert that even with contact, the results are same. And difference is biometry in contact is cylinder is only 2, but in Barrett it is 1.44. This is a slight difference. Here, you all know the online calculation, and the print shows that where is the placement of the lens. Your lens should be placed at 75-degree axis. Now, they calculate that toric IOL power with its axis of placement. And before that, we should do marking. Marking is 2 marking. One is reference marking, one is axis marking. Reference marking should be done on patient sitting position. Here is a small video showing the reference marking. You show that the patient is asked to sit down, and then asked to look straight ahead, and 2 marks are, usually I give 2 marks on the nasal and temporal quadrant, that is 0 and 180 degree. This is the reference marking, because when a patient lie down, there is slight rotation, cyclotorsion of the eye. So we use this reference marking to mark the axis mark of the patient. Then again, we can mark with slit lamp. You all know. We can again mark with toric, that is in the toricam marker, we can use it. Here is the axis marker. Usually, commonly we use this axis marker, and before axis marking, we always want to be keep in mind that left side is always 0, both eye. left side of the left eye and left side of the right eye is always 0. Here, is two small clip showing the axis marking. Another thing, it is nothing related with tonic, but during Rexis, this is a very low cost instrument. It is known as Rexis marker. So those who are not confident about their Rexis, whether the Rexis is central and circular, we can give an impression on the cornea with this Rexis marker, and then the Rexis can be, even the expert, I have seen that I usually do not use this Rexis marker, but last few days for test I use this. I see that the result is very good. And the surgery is simple. The phaco surgery is uneventful phaco surgery, and insert the IOL 20 to 30 degree off axis, and then completely clear the viscoelastics from behind the IOL and from the front of the IOL from the anterior chamber, and then final tuning of the lens, final placement of the IOL, and final tuning of the lens, wound closure and wound hydration. And here is only 2 video clip here. You saw that here I am giving the axis marking first, then I give the incision. Incision is normal self-sealing tunnel incision. Then the left side I use a Rexis marker. On the right side it is without Rexis marker. So round central circular round Rexis about the size of 5 millimeter is good enough. Then good hydrodissection. Then nuclear management is usual. All surgeon has his own choice of managing the nucleus. Here, I think it is visible that phaco is done in my usual way, and there is no specific choice. Any surgeon, he can perform the phaco in his own way, and after completion of the phaco, then cortical cleaning should be meticulous. There should not be any cortical remnant. The back should be clear, and then insert the IOL in the usual way in the anterior chamber. Here, now I am going behind you can see that I am going behind the IOL and trying to clean the viscoelastics completely. And then here is the axis mark, but the lens is away from the final axis. And then I am clearing the viscoelastics from also the front of the IOL, and then from throughout the anterior chamber. And then finally, I am trying to place the lens. I am here, it is the marking point and it is the lens. It is already in the axis of the marking axis, and lens are in the same line. Here 75 was the mark, and here is another same. It all are manual, so no need of any without digital it can be performed, nicely performed here. Then one thing is during wound closure, wound should be closed in such a way that it should not be, AC should not be too tight or should not be too shallow. When you remove the IAT from the anterior chamber, the anterior chamber should not collapse. This is the thing should be taken care, that your anterior chamber should remain as it is. It should remain formed, and eye should not be too tight or too loose. It should be hydrated in such a way that optimum anterior chamber should be formed. And after completion of surgery, 1 hour bed rest is good, because most of the rotation occur 1 hour after surgery. And postoperative position, check the postoperative position of the lens after 1 hour. Here we can check the position of the lens. The lens was calculated 75 degree. Here in the slit lamp, the beam of the slit lamp is placed on the mark of the lens, and here on the slit lamp scale, it is 75 degree. And another thing you can see here that, oh, sorry, here, here this is a print. Today, the surgery was done in last Monday. Today is Wednesday. This is the print taken. The vision is, left eye vision is 6.6, and this is the eye print, auto print of the left eye. So there is no spherical and refractive cylindrical error. So it is a toric surgery is a good surgery. Thank you all for your patience hearing. Thank you.
Thank you, sir. It was a wonderful, elaborate presentation, and I know many of us will obviously start toric after your presentation. And we have many questions coming in. This we will take after all our presentations. From toric, now we will move on to presbyopia correction during cataract surgery. I would like to invite Dr. Ashraful Haq to share his screen and give his presentation on incorporating presbyopia correction during cataract surgery.
Thank you, Dr. Maziba. Is my screen visible and I am audible?
Yes.
Assalamu alaikum. It's an honor and have a great opportunity to present in front of my mentors, and I would like to congratulate and show my gratitude to BSCRS for involving me. So incorporating presbyopia correction during cataract surgery and how I started. It's a story rather than surgical tips. So nowadays, the cataract surgery is not only the cataract surgery, it's become a refractive surgery. And when after the cataract surgery, we can manage the patient without glass, good vision, the patients become happy. And the happy patient always makes the surgeon happy. So, but starting for the premium IOL like multifocal IOL and the presbyopia correction. So what was the barrier for me when I thought that I will start the presbyopia correction? The most fear was the outcome. Will my patient be happy? Will my patient become the 6.6 or N6 vision near after the surgery? And what should be the biometry? What will be the power I calculate? And definitely the most mental barrier was the cost of the package. I am offering the patient a higher package surgery. Will the patient happy after the end of surgery? These are the barrier for starting the multifocal IOL practice. But the urge of becoming a refractive surgeon in a surgeon is the most important thing. And when we check the K1 and K2 in our biometry in every monofocal lenses and check the target refraction of the monofocal IOL implantation and monitoring the postoperative refraction of my routine cataract patients, it gives me confidence that yes, my routine cataract patient, they can see 6.6 after the surgery and they're seeing good, but they are not happy. Some patients are not happy that they need reading glass after the surgery, though they can see clearly distant without any glasses. So that's make me determine that yes, I need to offer multifocal IOL to the patient. And when we are offering the multifocal IOL to the patient, that is the initial phase, and choosing the ideal patient is very important. The patient who are desperate that yes, I don't want any glasses after surgery, either it is near, either it is distant. These are the very good candidate for the multifocal IOL implantation, and the less demanding patient. The patient, when we do the counseling, the patient who have confusion in every questions and every answers, initially for starting the practice, they are not the good candidate for multifocal IOL implantation. And obviously, no other ocular pathology and any ocular pathology should be ruled out for a suitable candidate of the multifocal IOL. And when we start the multifocal IOL, though we are doing lots of monofocal IOL implantation, the surgical steps are pretty same like monofocal IOL. But what should we consider of implanting the multifocal IOL? Number one is biometry. We have to check the biometry. Number two, surgical steps are same, but in every step, we should be and we need to be careful. And we have to keep in mind in perioperative time, we should avoid any kinds of complication. So here I'm showing the biometry. We are seeing and checking the biometry before the cataract surgery. But one thing for the multifocal IOL choosing patient is very important. That is my K1 and K2 value. My K1 and K2 value, a difference should be less than 1 diopter. If the patient has the more than 1 diopter of astigmatism, the patient will never be happy in only multifocal IOL implantation. The patient need for multifocal toric IOL, that will be the separate chapter. But for only multifocal IOL and only presbyopic correction, we need to have thing that the patient has the less than 1 diopter of the astigmatism. And other procedure of the biometry are the pretty same. We can go for toric, we can go for SRK. And here I am showing the IOL master, but in ultrasound biometry, immersion biometry, that also gives us a very good IOL power for choosing the multifocal IOL. But one thing is very important. Keep in mind when we do the biometry, the A constant of the multifocal IOL is very important, and we need to put the A constant of the multifocal IOL in the biometry. This is basically the first case of my multifocal IOL. She is a 65 years old female, and in the multifocal IOL surgery steps is pretty same, but the rhexis is the most important part. I need to have a good rhexis because I want to capture all my IOL in the rhexis. And the surgical step is very pretty same, but need to be careful. And also when we go for the cortical removal, we need to have proper and full cortical cleaning. We don't want any post-operative posterior capsular opacity. That is very important. And we need to have the meticulous polishing, because when the fiber are attaching in the posterior capsule, with polish we can remove this. And inserting the multifocal IOL, this is pretty same as monofocal IOL. Here I was using Restore. And after inserting the multifocal IOL, the most important part is that we need to remove all the visco from the eye. And also we can see the two Purkinje image. One image is in the cornea and one is IOL. We need to match it before we closing the surgery. And that patient, what I did in 2018, the first POD vision was unaided, distant vision was 6.6 and near vision was N6. And this is the actual post-operative first POD picture of that eye. And when we get the result of these kinds of surgery, this gives us the high confidence that yes, we can correct presbyopic in our cataract surgery, and we can offer patient further for the multifocal IOL implantation. So my take-home message for the presbyopia correction is that though we are doing the monofocal IOL in our routine practice, the mind setup that we will keep our mind open, that we can offer the patient that yes, you can go for presbyopic correction, that you will not need any glasses after the cataract surgery, that is distant or near. And obviously the proper preoperative evaluation is very important. And with this, if we are aware of this and you can keep in mind, and we are determined that yes, we can go for not only cataract surgery, we can go for cataract and refractive surgery, that will give us the confidence and we can go for cataract refractive surgery. Thank you very much.
Thank you, Dr. Ashraf. I know that your presentation will give many a surgeon confidence to start their presbyopia correction during cataract surgery. And now we will hear from the expert. I would like to invite Dr. Mahbub Rahman Chaudhry to give his presentation on presbyopia. Sir, will you please share your screen?
Is my screen visible?
Yes, please go to presenter's view.
Is that fine?
Yes, please. Thank you.
Thank you, Dr. Ashraf, so for a wonderful presentation. And I will just give some overview of the presbyopia correction during cataract surgery. And I thank Marziba for giving me the opportunity, and also I thank the President, Secretary, and the whole Executive Committee for organizing this webinar. And as Dr. Ashraf said, cataract surgery was vision restoring surgery, but nowadays it is a refractive surgery. So we should look into that this status that it is actually a refractive surgery now. So that's what we are aiming at. So what is the aim? As Dr. Ashraf said, quality vision for distance, for near, for intermediate region. So we want to have vision for all range. That is the aim. And if here, two things is important: selection of patient and counseling of the patient. And this is more of an art than science. So we have to take some time here, and we have more time here. The chair time is very important, explaining to them, converting normal cataract surgery into the refractive surgery. So the chair time is very important. And this is an art that we have to master if we want to be a refractive cataract surgeon. And as Dr. Ashraf said rightly, who are the patient? So initially we should see that we have to make a judgment so that this patient become happy and this patient doesn't become chronically a problem for a surgeon. So we want to select the right person, and the ideal persons are those who want to reduce their dependency on glasses, those who are motivated, those who have a fashionable and cosmetic lifestyle, and those who are ready to go for bilateral implantation in short period of time. And as Dr. Ashraf said, it should be the astigmatism part. We must look into this, that it should not be more than one diopter. And some patient, as we know, that they are complaining sort, patient with unrealistic expectation, complaining patient about glasses or contact lens, and those are night drivers and with ocular pathology. So these are the people we want to avoid so that they don't they don't blame the multifocal lens or the trifocal lens or the EDOF lens. It is the counseling part and is the selection part which gives the most important in this effort and in this criteria. So when we are counseling, we have to explain to the patient the cataract surgery is now this is an opportunity to have the best of the vision, which you never had. So we can explain that. So you take the best. You should take the best because this is an opportunity and you must avail it. So if we can explain it to them, and we'll say this, the quality of life will be much better. We'll be able to see most of the things without glasses. And the cost part, we'd say if you buy 5 pair of frames and lenses, this will bear the cost of the surgery, which is of premium quality. So, and we have to insist that to get the best result is the bilateral surgery is the most important, and there is neuroadaptation and other things are related. So we will say that we will get the best result when the surgeries on both eyes are done. So we take a lot of time for selecting the patient and counseling the patient. These are two important aspects I will emphasize time and again before we go for this. And at the same times, we have to point out some of the limitations that with the patient will see halos, will see glare, and will take some time for neuroadaptation. So if we explain this thing to them beforehand, they will be not disappointed, and at the same time will not emphasize this limitation so much so that they will become scared to use the multifocal lens. So there has to be a balance between how much information we want to give, and at the same time how much information we need to preserve. So pre-operative evaluation is very important, as Dr. Ashraf was saying, that am I going to get a good result? And this is one of the barriers that we have in our young ophthalmologists who are about to start this presbyopic correction or toric correction. So this barrier has to overcome, and this is, accurate biometry is one of the most important factor, and this is the most important confident. It will give the most confidence if we have proper biometry done, and if we get the target refraction for, let's say, if we select 30 or 50 patients that I'm doing monofocal, am I achieving that? Am I achieving that? If I achieve my target refraction, I know that I'll be able to do a good presbyopia correction as well. So as Dr. Ashraf was saying, we should look into the biometry very, very meticulously, especially if there is there any cylindrical power here? It is more than, is K1, K2 is more than 1, then we should avoid it. So we should ask the patient to go for toric lens rather than the presbyopic correction. And if they insist, we can prescribe what we call the toric multifocal lens. So biometry, we have to consistently achieve, and at the same time look for astigmatism and the new generation formula. So Barrett toric calculator is the most important formula that we use now, and this is so helpful, and this is so easily available in the website of APSCRS. And we have to, since this is a presbyopic correction, we have to see the retina, cornea, glaucoma, amblyopia, dry eyes, because if these pathologies are there, the patient will tend to blame the presbyopia correction lens for their dissatisfaction. So we have to look into this before we go for cataract surgery. Surgery, as Dr. Ashraf is saying, is same, but for myself, I take 1 or 2 minutes extra, because I had promised the patient a premium lens. So I want to see that the REX is properly done. I want to see that all the steps are done, and I want to prevent complications. So I take few minutes extra while doing the surgery, so that I can implant the lens that I promised the patient. So there's the same surgery, but what I want to emphasize is that we have to take extra few minutes so that our surgery can be done smoothly and also without complication. So this I will go to the next year. So, this is one lens that we have used, and I will go for this. The time is short. This is the Adolph lens. The other one was the Panoptix. So this is what we want to show. And as Dr. Ashraf said, the 2 Purkinje images should match. So that is we know that the centration is right. The patient satisfaction will be also very. And how to stop? As Dr. Ashraf said, so these are the mental barrier. And we be a good phacosurgeon. And we have to achieve consistent target emmetropia for biometry. And we have to record this, and we have to take this mental barrier that I am a good surgeon. I will be able to give the patient the best result, and the best confidence is performing one surgery, as Dr. Ashraf and Dr. Zakia Wadud has said. And we have to first patient should be selected very meticulously. They should be motivated. And the patient who was not fussy, and maybe a housewife, it would be an ideal patient to start with. So with this, I thank all the organizer for giving me this opportunity, and thanks for everybody for giving me the patient hearing. Thank you.
Thank you, sir. That was an excellent presentation, and you seem to make all the surgeries so easy. The questions are pouring in, but we will wait till the end to answer the questions. So now we will move on to the white cataracts and how to tackle them. I would like to invite Dr. Shams Mohammad Noman to share his experience on how he manages white cataract. Dr. Noman, please share your screen.
Is my slide visible?
Yes.
Am I audible?
Yes.
Thank you, Dr. Majiba, for your introduction. And I'm really delighted to have with you with the Bangladesh Society for Cataract and Refractive Surgery webinars. It's a great opportunity for me being with you. And I don't have any financial issue related. with this presentation. The white cataract, how I manage my topic. So this is a case of Fuchs uveitis syndrome, unilateral cataract of a young female. And I started phaco surgery with a average 5 to 6 millimeter capsular axis. And that was a single capsular axis, not a double. And I didn't do any hydrodissection or delineation because as it is a very soft cataract, I did it very easily and with a very less phaco power. And I implanted an intraocular lens. So in this cataract, it looks like a softy ice cream. It's very easy doing this. And this is a white and hard cataract. And in this case, I'm doing a relatively larger capsular axis. And as it is a very tenacious cataract, so I have to take care of the endothelium and also the posterior capsule. And after doing, I did the stop and chop technique, and I completed the IOL implantation. And this is a case of phaco in white traumatic cataract. And I did a very small capsular axis here, as it is quite a traumatic cataract, but it is soft. So thanks God for this. And after phacoemulsification, I'm giving the CTR ring here. Here, for me, and when I starting my phaco surgery with CTR ring, I felt some complications. I felt some difficulty placing the CTR ring because there is some genular dialysis, and even I felt some difficulties IOL implantation, and after CTR ring implantation, I implant IOL in a very perfect way. And this is a case of manual small incision cataract surgery in a very subluxated lens, but a little subluxation lens, but it's with a very flat anterior chamber. So I was not very much confident doing phaco in this case. I did manual small incision cataract surgery as anterior chamber was very flat, and even it is large nucleus, and it was so difficult to manage the nucleus also. And I ultimately successfully removed the nucleus from the anterior chamber, and I gave the CTR ring in the bag, and after that I implanted intraocular lens. This is a manual small incision cataract surgery in a white Morganian cataract. And in a very preliminary stage, I was not very much confident doing the phaco surgery in such cases. But in these cases, sometimes I have to do a lot of cases, Morganian cataract. I did the puncture first, and then I removed all cortical materials from the anterior chamber. Then I again inflate the bag, and after the inflation, I just remove the nucleus, and then I put the intraocular lens here. And this is a very interesting case, phaco in a white hard tenacious cataract, and it was a vitrectomized eye. When I did the surgery, the anterior chamber become deepened, and that was really a very tough thing for me because during vitrectomy surgery, there might be a possibility of PC range, so we have to take care of that. And in that case, the bottle height should be minimum, and we have to take care of the capsule, and we have to take care of the cornea and everything. So in that case, that we have to think that pre-existing precedent can be associated with that. This is another case of white but a little bit hard cataract. In this case, I made a bit larger capsular axis, and I did hydrodissection in such case, but with careful hydrodissection is very much important. And in that case, I did 4-quadrant nucleus sculpting. And after that, the nucleus removal was quite easy for me, and I did the IOL implantation. So actually, what is hypermature cataract? We know everybody the vision should be hand movement or PL. Intraocular pressure can be normal or a little bit increased, and capsule can be thinning, can be thickened or calcified, and cortex can be leaked, can be liquefied, and cortex can be absorbed. Nucleus hardening or sinking like a Morganian cataract, and posterior capsule may be thinning or leaking. And journal can be weak, and sometimes it can occur the subluxation can be associated. So in my clinical practice, I used to measure some important issues like I measure the intraocular pressure preoperatively. I do the B scan, and I have to take, I usually search for any subluxation or not. And also I am taking the history of any anti-glaucoma medications. Obviously, I had to take care of the Fuchs uveitis is associated or not. And for the Fuchs uveitis, I had to start, as it is a mature cataract, I had to start the preoperative topical and also systemic steroid after consultation with the UVI specialist. And this is one of my study, internationally published study, where why the intraocular pressure measurement is very much important in case of hypermature cataract. According to the study, 20% intraocular pressure more than 20 millimeter of mercury in my study, and also in the compromised visual outcome in 20% cases if it is raised intraocular pressure. So what are the challenges in the managing the hypermature case or white cataract? Creation of contributor curvilinear capsular axis, intralenticular pressure is the factor, poor or lack of red reflex, cortex in the anterior chamber, sometimes cortex in the anterior chamber, even in the posterior and behind the posterior capsule, and weak journal, obviously it's also a challenge. So I'm following the irounds.org, which is also approved by the BSCRS. How I am improved the surgical view. So dim operation room light is a great factor, but usually I don't do that. But if for the beginners, it can be done. Microscopic magnification is a great factor, coaxial illumination, and trypan blue stain to increase the contrast. Hydrodissection and nucleus management. If it is a hypermature cataract, so hydrodissection and hydrodelineation is very much important, and there might be associated journal weakness. So if it is a Morganian, no need of hydrodissection. Viscose shell technique is very much important, removing such type of mature cataract nucleus. So we can give the sodium hyaluronate in front of the nucleus and also behind the nucleus to protect the cornea and also protect the posterior capsule. We can use direct chop or divide and conquer, but in the Morganian cataract, I don't prefer direct chop. Uncontrolled capsular tear reduction. How can we control the capsular tear? Because it's a very common complication during doing phaco or any SICS surgery during while managing the hypermature cataract. So 2-axis capsular axis that was invented by the Gimbel in 2003, and also you know, the one-stage procedure can be done. That was also invented by the Kara in 2009 in case of, and also capsular puncture can be done. And even Yag laser capsulotomy can be done, which was discussed by the Richard Harrison in 2002. Yag laser capsulotomy can reduce the intralenticular pressure pre-operatively. So this is a picture of a capsular extension. This is a very common complications. And to me, I experienced a lot of cases where the cortex behind the posterior capsule I got. This is one of my cases, preoperative case. And the first picture is first postoperative day. There is some cortex behind the capsule. So sometimes even in the operation theater, the beginners, and also when I was started my surgery, I was very much anxious, what should I do? And so getting experience, I saw the lipid cortex behind the posterior capsule become absorbed with time, and we don't do anything for that. And this is my last slide. So what should be done actually? I know myself, and I have to calculate my confidence and commitment, confidence over me and commitment towards patient. I have to calculate both of them. I have to take care of the economy of the patient, and I have to take care of the my experience or outcome of my surgery. And I have to do whatever I can, and I have to take care my limitations. Thank you. Thank you, everybody.
Thank you, Dr. Noman. We got a very excellent point from his presentation that when we are beginners, it's better to avoid the white cataracts. Once we get ourselves accustomed to phaco, then we should move on to this. But and now I would like Professor M. Nazrul Islam to share his experienced talk on tips for management of white cataract. So will you please share your screen?
Yeah, I'm trying. Oh, no. Is it visible now?
No, sir. Double click.
Is it visible now?
No,
No,
no, sir.
sir.
Oh,
You have to double click on that.
okay, okay, just a minute. I'm sorry. Let me stop it first, then it will be better. Now, can you see?
No, sir.
No, sir.
Oh my God.
Sir, can you share again? You're not sharing now.
Oh, just a minute. Can you see now?
Yeah, it's visible now.
Yes.
Okay, okay. Thank you very much. Sorry for the interruption. Dr. Shams Muhammad Noman spoken very nicely and elaborately about the white cataract. And I think he has covered many points. Mostly he has given the importance on the pre-operative evaluation, especially if they having any secondary glaucoma, uveitis, any trauma, all these things. Regarding the trauma, he has shown a video clip. I think in the traumatic cataract, you must be confident that there is no jonular deficiency, there is no posterior subclavicular PCR, because it can happen in the traumatic cataract. It's really important. And CTR must be ready in most of the white cataract. He has nicely shown. And SICS, of course, I will request the beginning surgeon, if you feel discomfort or uncomfortable with the white cataract, definitely SICS is a good choice. No harm for that. And if you're confident, you can manage all type of cataracts most of the time. So I think he has covered many points, and I will try to cover some points more. Well, first of all, I like to give importance to the preoperative evaluation, especially the slit lamp examination. And you must exclude the patient do not have any zonular deficiency. How is the dilatation of the pupil? The anterior convexity of the lens, is it very much intralenticular pressure is very much or not? Already Dr. Noman mentioned that exclude the uveitis, secondary glaucoma. And as the patient posterior segment cannot be visible due to white cataract, all the cases should have the B scan, because to see the retina, is it flat or not? Is there any vitreous opacity? Is there retinal adjustment? We must see. And in the slit lamp, we must determine what type of white cataract I am having. Is it intumescent only, or it is a simple sandy cataract? Is it a white soft cataract? Is it white hard cataract? Is it Morganian cataract? So we must have a presumption that what kind of cataract I'm going to deal with. This is a very important slide, because before going to manage a hard and white cataract, you must counsel the patient. We must tell our patient that this is a complex surgery, this is not as usual surgery. So we should have kind of plan A and plan B. If plan A goes fine, is fine. If do not, then we may have to change our lens model. We can have to give 3-piece IOL, or even I can take the help of my retina colleague. Otherwise, if we have any complication, the patient will not accept. So I think very important that we must tell the patient about everything. The most important part is the intumescent cataract in white cataract. because Dr. Daniel Mario Peron, he first published this report in 2000 that you can have an Argentinian flag sign during your cataract surgery, especially in the capsular axis, because of the very high intralenticular pressure in this kind of pearly white and white cat and compared to softer and harder cataract. And here the CCC is the most difficult part, and sometimes the typical Argentinian flag sign is not uncommon. The report said that about 28.3% cases you can have the Argentinian flag sign. People are trying how to decrease the intralenticular pressure by needle. Many people have tried. I have also tried, but I do not feel much comfortable because in some cases, even the needle prick can bring your capsule to radial tears. So I don't think that it is sometimes easily. Dr. Mohan Rajan got the prize in the BSCRS by showing the puncture axis. Beautiful. You can do with the phaco probe by phaco probe, but you see, in his own hand, sometimes it can have a radial tear. So it is not even very useful in all these cases. Yes, nowadays, recently we use the flax, is really reliable. And for the white cataract, you can have a beautiful round axis, and it is really reliable in most of the time. I'm really happy. I tell my patient, if you can afford, we'll go for the flax, and you will get a very beautiful round axis. And we can put any type of IOL, maybe toric IOL, maybe multifocal IOL, nicely told by Dr. Mahabharan Chaudhary. The multifocal IOL is the choice of IOL nowadays for a very good quality of life. But according to Dr. Soon Fake's study, in 17.2% of cases, the capsular axis was not complete. So that is the tragedy. Sometimes even the plaques, you might have the incomplete capsular axis. In the Conrad and Hengrader, they have found out of 25 eyes, 2 eyes had the radial tears. So it is again not 100% that you may not have any tears. But fortunately, in many cases, single axis is enough because there is no leaking fluid, there is no interlenticular pressure. So single axis is quite good. But double axis is my choice. And I am practicing in the last 15 years is the double axis. I find even not 1 in 100 have any problem. So I think I will request my colleagues, my students, my junior colleagues, try to do this in your practice. The double axis in my hand, it works very good. Simply important is that you can use your needle or even you can capsular axis forceps. Important is when you puncture, you hold it. You just hold it, do not release it, and quickly make a small axis, maybe 2 millimeter, maybe 3 millimeter. You make a small axis, and then you wash your liquid and milky fluid by either Simcoe cannula or even your eye cannula or bimanual cannula, no problem. And I will suggest my colleagues, please use the high density cohesive viscoelastic in these cases, especially in your beginning, because this is the viscoelastic that makes your life easier in the this kind of intumescent cataract. If you use the cohesive viscoelastic, the anterior chamber is pressurized and usually there is no radial tears. So you can make a very good rhexis, double rhexis, and all kind of good rhexis you can make. Most of the time, you will find the cataract is not much dense. Sometimes it is sandy, sometimes it is soft, and rarely it is very hard. So most of the time is like this. It is 2+ cataract. So very easy for a phacosurgeon, very interesting. Only problem is the last piece because you do not have any support. You do not have any the epinuclear cortex here. So it is very important to take care of the last piece. And finally, you can put your IOL, whatever IOL you want to give, you can give and you can come up. Even with the double rhexis, if you are not careful, it can have a mishap. Let us see an example. I could not make a complete small rhexis. You can see there is a nick here. So this is the danger. You can find this nick can go to the radial tear. So I am very careful during cleaning of the liquid here. Whenever I found it is getting a little bit leak, then quickly I got out and given the viscoelastic, and I used the micro scissor here, and I am requesting again purchase a micro scissor, because in this cases micro scissor is really of good help. You can use the Venus scissor, you can use other scissor, but I find micro scissor is really of good help. It is a hard cataract. In the slit lamp, I found it's a hard cataract. You can make a single rhexis here, but you see, I have done a double rhexis. Why? Because I do not want to take any risk. I know I can do it a single rhexis, but if I do a double rhexis, no harm at all. So in my practice, in the white cataract, I try to do double rhexis in most of the cases, because I feel very confident when I do a double rhexis, I can make a very important, this is a hard cataract, so you need to do a comparatively larger rhexis, at least 5.5 millimeter larger rhexis you need to do. So if you make a double rhexis, definitely you can do it. So it's no harm, and you can have your stop and chop, and it's comparatively harder cataract, you can see here. And you can make whatever amount needs. And last piece, again, the same thing, you should be very careful. This is the comparatively harder cataract. And there is a question here. When there is a harder cataract, there is a Morganian cataract, the nucleus is small, it is going here and there. What to do? Actually, it is better to do the direct chop. You hold the nucleus and make the chop. But even then, there is a lot of risk in these cases, because granules are very weak. There is no epinuclear plate. So you are always in threat that you can make the post-capsule rupture. So it's better give the scaffold by your intraocular lens. Put it in the bag or in the sulcus and do your nucleus management slowly. And most important is that give viscoelastic, preferably dispersive viscoat many times during your surgery. Then there will be no much defect in the cornea, the protection of the endothelium. This is a soft cataract in the white lens, white lens, but soft cataract. You can see the management of soft cataract is same in white cataract, in other cataracts. So done the small rhexis first, then make the larger rhexis, and then manage your cataract. Why I'm showing it? Because you will see I am not doing any energy here. I'm not using any energy here. You can see CD is only 0.83. Most of my maneuver I am doing it the mechanical, just mechanical fracture, for all kind of soft cataract. Give the mechanical fracture. You see, still CD is same. So I am only taking my quadrant, taking my cortex by energy, but fracture I am not giving any energy. So even in this kind of white cataract, you should be very careful. Do not give chop. Do not put any chop. If you want to make chop, it will go through and through. So be very careful. And you see, the whole cataract has been emulsified less than 3 CD. So it's very good that you use your mechanical forces. It is the last, Dr. Noman also showed that when you find difficulty, I found difficulty in rhexis here, it is fibrotic, so I didn't take any risk. I made the capsule rhexis by manually, make the conversion, the SICS, and I did the surgery SICS, and the next day vision is 6/9. So I think when I'm in doubt that my rhexis is not circular, my rhexis is continuous, definitely no harm. You can convert to SICS and give good vision to the patient in the next day. So this was some of my tips that how we can manage the white cataract and we can give the good vision to my patient. Thank you very much, Dr. Majiba.
Thank you, sir. That was an excellent presentation. And sir, as sir was explaining over and over again, that the main problem with the whites are the rhexis. So if you're careful at that time, the whole surgery should go smoothly. Now from the whites, we will move into a little harder part, that is the hard cataracts. I would like to invite Dr. Sarat Rahman to present on how she manages hard cataracts. Dr. Sarat, please share your screen.
Assalamu alaikum. Thanks, Dr. Maziba. Is my screen visible?
Yes.
Big thanks to a big thanks to the BSCRS president. Am I audible?
Yes, you're audible.
Okay. So a big thanks to BSCRS president and all my teachers and mentors for giving me the opportunity and platform to talk today. And I want to start with a beautiful quotation from Rumi. As you start on the way, as you start to walk on the way appears. And today I will talk on hard cataract, how I manage. Despite the recent advantage, techniques and technology, phacoemulsification with hard cataract is still challenging even in the hands of an expert surgeon. The greatest fear for me for doing hard cataract was its high incidence of capsulozonular complication, PC tear, nucleus drop, and corneal edema. But with the continuous guidance of all my mentors, I was able to overcome my nightmare. And today I will show that with proper surgical strategy, good results can be delivered in a continued manner, even in these challenging situations. A meticulous preoperative evaluation is absolutely mandatory because the surgical strategy depends a lot on the preoperative findings. I always look for the maximum zonular maximum mydriasis evaluation. And if the mydriasis is poor, I always keep ready the pupil expanders. And I'll always look for the zonular weakness. If there is any zonular weakness, I keep ready the CTR ring. And if the fundoscopy, if the posterior segment is not visualized, I always prefer to do a B scan. For hard cataract, I always prefer to do perivalvular anesthesia. Before all surgery, I set up my strategy as my mentor, Dr. Mahbub Chaudhary, always said. So for hard cataract, I always tell myself to have patience and take your time. And I always use adequate amount of OVD. Before each surgery, I check and set up my machine parameters. For nuclear management, I go for deep and wide range and do the complete separation and try to do as many small pieces as possible. Everybody has their own parameters, and my setup is for sculpt, I keep the power at 100 for and for chopping, I do keep the vacuum at 500, which gives me a good hold. And for quadrant removal, I keep the parameters or in higher side. I always prefer to do a temporal clear corneal incision. And an intact large capsular axis is the paramount for hard cataract. The large axis helps in easy nuclear maneuver and prevents zonular stress. In absence of good red fundal glow, staining the capsule with refined blue helps facilitates the capsular axis. In case of very hard cataract, fluid wave may not be seen. Hydrodissection should be performed very carefully to minimize the rapid pressure rise and thus preventing the posterior capsular rupture. And nucleus should be mobilized and freely rotating. As we are using very high power for hard cataracts, the endothelium should be protected. The endothelium protection is best achieved by dispersive OVD, which retains as a protective layer. An arsenal soft shell technique is best in this regard. Before starting the nucleus management, I keep the tip, phaco tip is, the phaco tip is almost 2 millimeter. For sculpting, I always do deep and wide sculpting, deep trench and wide, at least 2 millimeter wide. So it easily facilitates phaco tip to go deeper with using adequate amount of power. My preferred choice for hard cataract is stop and chop, especially the vertical chop while doing the hard cataract because it reduces the total energy used. First, I engage the nucleus with high power and then proceed to crack by lateral separation. It's safer and less traumatic to the capsular bag if we do the lateral separation in multi-layered as I am doing here. And the separation must be complete. I try to do as many small pieces as possible, taking care not to damage the posterior capsule with the sharp chopper. For quadrant removal, I keep all the parameters in a higher zone. And if we are encountered with a big piece, you can see that it's a very time consuming and it requires more power to emulsify than a small piece, which is emulsified very easily with less power. So whenever we are encountered with a hard piece, we must do another chop in this phase. So it easily can be emulsified. Before the removing the last piece, I always come out and fill the bag with OVD and then remove it safely in epinuclear mode. The rest of the surgery, the cortical cleaning and IL implantation is the same as for all grades. I prefer bimanual technique because it's easier and comfortable for me. First cleaning the one half and then changing the hands and cleaning the other half. And then putting the IOL. I give more time for cleaning the viscoelastics because as I have mentioned earlier, we use dispersive OVD, which have a tendency to retain, and it should be removed meticulously from both the above and beneath the IOL. So phacoemulsification is challenging in hard cataract, but it was a nightmare for me. But with judicial mix of proper planning, adequate technology, including the power modulation and enhanced predicts, the road was easier for me. Thank you all for your patient hearing.
Thank you, Dr. Sarwat, for your wonderful presentations on how you started your hard cataracts. Now we will move on to Dr. Mohammad Shaukat Kabir, who is going to share his tips on management of hard cataract. Sir, will you please share your screen?
Is it visible?
Yes.
Thank you. Thank you, Dr. Mahajiba. Before presenting my presentation, I would like to thank Dr. Sarwat Rahman for excellent presentation. Actually, she covers all the aspects which I would like to talk. I just summarize and show my few tips and tricks. So I'd like to talk on management of hard cataract. First of all, we have to plan for surgery. At first, we must counsel the patient that this surgery is a little bit difficult and it takes longer duration, and there may be a chance of complication like zonular dehiscence and other things. We must explain to our patient, and sometimes we may need to convert. So in that case, we should assure a patient that if conversion needed, it will help not help him or her, and sometimes we need to help from retinal surgeons, and sometimes in first period a week 1 week time needs longer visual recovery time. And so planning of surgery, first of all, The surgeon, myself, should prepare for the challenge, and we should be calm and take over one step at a time. Don't rush, and we should have to have sacrifice our egos, and we should also consider the patient safety first, and that way we can be winner by changing our plan. So if we need to protect endothelium, Dr. Sarod Rahman rightly said that we should have to use viscoelastic dispersive type, soft shell technique, and multiple use of OVDs. I would like to demonstrate how we can use the soft shell technique. First of all, we use the dispersive, and then beneath it we use the hypromellose, and it will protect the endothelium. Capsule, we should for better visibility we should stain the capsule with uh, trypan glue. This is how we can stain the capsule. Also, the capsular exercise would be easier. Rexis, usually we prefer to do larger exercise, 5 to 5.5 millimeter of diameter for easy. It is easy for easy nuclear removal, and which also prevents the jonular stretch during nuclear management. Here I'm doing trying to do larger exercise. I usually do it by uh, anti-clockwise. Usually everybody does clockwise, and I try to do it is around 5 to 5.5 millimeter of rexis, and it is done completely, and we have done a good rexis. Proper parameter, there should be high power and high vacuum and moderate flow rate. Nuclear management we can use by stop and chop technique, and for sculpting we should do a deep trench. Usually rule of thumb is for grade 1 cataract we do a trench of 1 millimeter, and for grade 4 or 5 we do as wide as possible, usually 4 to 5 millimeter. And for trench we should go as deep we can go. Usually when we see the yellow sheen after trenching, then we stop the doing trenching. Nuclear management, uh, for chopping use high vacuum. We always use longitudinal during chopping, vertical horizontal chop, or both we can use it. Multi-layer chopping and lateral separation is necessary, and achieve a complete separation. Make multiple pieces in the same manner. Here I am trying to show how I do the trench. It is relatively wide, 3 or 4 millimeter or around, and we are going to deep as we can, and then we used a stop and chop technique, and complete trying to do a complete separation. Here I am trying to do multiple chopping. It is a grade 4 cataract, and try to do in complete separation. When we are sometimes we need to do multi-layer chopping. Usually I do it by Sinsky, but it is better to use chopper, sharp chopper with blunted pointed tip is better, I think. Nuclear management, quadrant removal. In during quadrant removal we should use the torsional power there should be high vacuum, 450 to 500 millimeter worker each, and work in safer plane. I mean, in the central iris pupillary iris plane, in the iris plane, and proper use of OBD. We can use repeated OBD when we need. There is another video of nuclear management. I try to do the nuclear management in the iris plane, and I am using copious amount of OBD. And for nuclear, the last piece is a challenging. Sometimes we can catch the posterior capsule. So during last piece, we also Dr. Sarwat Rahman said rightly that we can go to epinucleus mode, so that this vacuum will be less. In this case, we can say it is a step down pattern. Here is we can also use by chopping multi-layer. This is a multi-layer chopping, direct chopping. In this case, we can remove first piece of nuclear segment, so that maneuver of nuclear management is better. If we face problem like if we had jonular dehiscence or PCTL, sometimes we may need to convert, and if there is a nuclear flare drop down, we can refer to a vitreoretinal surgeon for proper management. So my parts will be most important is the counseling of the patient, mental makeup, protect the endothelium, stain capsule, usually a larger rhexis, use proper parameter, complete separation of the heminucleus is necessary, make multiple smaller fragments for good nuclear management, be careful during last piece of removal, and take your time. Thank you BSCRS for giving me opportunity to present my presentation. Thank you, Dr. Mahdiba.
Thank you, sir. That was a wonderful presentation where sir has explained stepwise on how to deal with those hard cataracts. Now we will move on to the complicated ones. So I would like to invite Dr. Muntakim Shahid to give his presentation on how he manages subluxation.
Assalamualaikum. Good evening. I am Dr. Muntakim Shahid. Thank you, Dr. Mahjiba and BSCRS for giving me the opportunity to speak here. I am presenting my way of managing subluxation of lens. So I have no financial interest here. And subluxation defined by the malposition of the crystalline lens when it is partially displaced, but lens confined within the lens petal fossa. There are so many causes, and management has two options: removal of the entire crystalline lens, including its capsule, and then vitrectomy, and then anterior-chamber IOL or fixation of the PC IOL by either fixing at the sclera or iris by suturing or glue. And the other option is preservation and suture fixation of the lens capsule to the sclera using the capsule stabilizing device. There's two kinds of stabilizing device. One is equator supporting and another is capsule supporting devices. So here my video. It is a traumatic subluxated lens with vitreous in anterior chamber. So initially we did vitrectomy and then remove the nucleus and doing irrigation aspiration. Then some vitreous collapse through the from two side of the nucleus. Then we do vitrectomy and put the CTR in the bag. And after that we inserted the intraocular lens. And this is another traumatic cataract. This is subluxation, and after the cataract surgery, we insert, but it is wrongly inserted in the subluxated part, so it doesn't go. Then we take it out, and again we insert in a right way. But this insertion is not ideal. We have to use the hole for the insertion of the trailing haptic, and then we insert the lens. These are other cases. There is a subluxation of the lens, and we using after doing DEXIS and all the nucleus management, we use CTR along with the capsular tension segment, the darkness segment. Both we are using here. And in case of subluxated lens, the phacoemulsification is better than the SICS, because during nucleus prolapse from the bag, the subluxation is increased. For this reason, phacoemulsification is better. In bag or subcapsular or prolapse in the antechamber, and then phacoemulsification is the best option. The CTR is applied within the bag. And then capsular tension segment, the darkness segment is fixed with the 10-0 Folin suture, and then fixed in the sclera, and then the lens is given within the bag. Here is another traumatic case, and we do a rhexis. The rhexis should be started from the supported area, and there should be minimum 2 millimeter capsular supported area in the subluxated area. The capsular rhexis may be different shape depending on the subluxation, and then we using the capsular tension hook for stabilizing the nucleus, and after that we are using the CTS, capsular tension segment, or Ahmed segment. This is a Ahmed segment, and that is fixed with the sclera with 10-0 protein suture, and then we inserted the follicular. It is a case of Marfan syndrome. We started the rhexis with the cystotome, but it's better to do with the rhexis forceps. Ideally, in case of any subluxated lens, it's better to do rhexis with the rhexis forceps. And sometimes the rhexis is eccentric, not centrally placed, because the lens is displaced in any part, and then we put the lens inside. It is a traumatic subluxated lens. We are confusing whether we go for the vitrectomy, baptismal and vitrectomy, but we try, and we see there is a huge subluxation. We use the 3 capsular tension hook for supporting the capsular bag, and using the two CTS component, one in the nasal side, one on the temporal side, and then we inserted the lens within the bag. It is another Marfan syndrome. The intake is jonular intake, but lens is displaced. So we do rhexis. The rhexis should be start with the forceps. It is better to do rhexis with the forceps, and always try to do. Sometimes rhexis goes behind the iris, and we are doing rhexis by only assumption, and then we use the bimanual, that is irrigation and aspiration, for removal of the cortical matter. And the tuning we are using. The tuning is applied in the bag. And after inserting the IOL, we centered the bag capsular complex by steady pulling. Not by the forcefully pulling, by steady pulling, because all the intake, jonular intake, so we have to just pull the capsular complex into the center part. This is a traumatic eye. We, after doing rhexis, we using the capsular tension hook for stabilize the nucleus for phacoemulsification. And after doing phacoemulsification, we did some vitrectomy. And after that, we are inserting the tuning here. And we are using the CTR, capsular tension hook, for supporting the capsular bag for inserting the tuning. And then we insert the intraocular lens in the bag. So these are some post-operative pictures of my cases. These are the chionary loop CTS. It is aniridia cases with there is a CTS in situ. This is double CTS. There is one in the nasal side, one in the temporal side. So thank you for listening.
Thank you, Dr. Muntakim Sharif. That was some excellent video demonstration of how one can manage subluxated cases. Now I would like to invite Dr. Ishtiaq Anwar, who is one of the top surgeons who does subluxation. So Dr. Ishtiaq, would you please share your screen and your tips on how to manage subluxation?
Okay, Dr. Maziba, I think yes, I'll share my screen. Is this visible?
Yes, sir.
Assalamu alaikum, and thank you. Those were some excellent videos, Dr. Mohtakim. Hats off to you. I mean, he has covered all the things. He has used all the devices that we use for managing this subluxation case. I just want to emphasize some of the points that I want to add to it, and I will skip the things that he has already covered. So one thing is that preoperative evaluation and planning. This is very important, as in all other complicated cases. When we are evaluating, it has to be very meticulous. We should write down that what are the things that we might need. What are the instruments, what are the suture materials like CTS, CTR, all these things should be there. And it should not happen that in the middle of the surgery, our OR team tells us that we don't have these sort of things. It just happened to me last week that after doing the Rexis, they told me that I don't have a capsular tension segment to manage such a case. So all these things should be prepared, and we should check ourselves whether that is there. And preoperative evaluation is so important. Like this case, I could not find that there was any subluxation during the preoperative examination, but when I started doing the Rexis, I could see that there were so many wrinkles, and at that moment I knew that I had missed something. Maybe I was not very much meticulous while I was doing it. So preoperative evaluation is one important thing. And the other issues that with subluxation, that there might be vitreous in the anterior chamber, as Dr. Muntakim has showed that we have to manage it. And if even there is no vitreous already existing, because of lack of zonules, there is high chance of vitreous prolapse. And the lack of zonules also causes very much problem where we are initiating or propagating the Rexis. And he showed nicely how to do those cases. And even Dr. Muntakim showed how to do Rexis when the part of the lens is under the iris. Like this is a subluxation, and we can see the beautiful zonules, but there is no vitreous disturbance here. But here we can see that in the central part here, there is a vitreous disturbance. So this we'll have to tackle this before we start the case. And in this third case, we can see that there is hardly any zonules in subluxated area. So the very moment we give an incision, the vitreous is going to come out. So we have to keep this in mind, and we have to proceed accordingly. So the first thing we have to do is we have to give dispersive OVD in the subluxated area to give a tamponade so that the vitreous does not prolapse in here. Also, this prevents fluid from going into the vitreous through the subluxated area. And if there is vitreous already in the anterior chamber, like in this case, this was a traumatic case, we have to do vitrectomy before we proceed to any other part of the surgery. And using triamcinolone acetate is a must for this sort of situation. This makes the invisible vitreous visible, and this helps for a thorough vitrectomy. So what are the devices? As Dr. Muntakim has nicely showed, that CTR can be used up to 90 degrees of zonular weakness. Capsular tension segment has to be used if it is more than 90 degrees, and CONE if it is more than 180 degrees. Either CONE, or we can use CTR plus CONE, or two capsular tension segments. One thing I want to mention, that what sort of suture should we use? This is a case that I had done, I think 8 or 10 years back, and at that time we were using 10-0 proline. So after 10 years, that proline degraded. So now everybody is suggesting that we should use either 9-0 proline or Gore-Tex suture. 8-0 Gore-Tex is the best one. This does not degrade over time. The management strategy would depend on the extent of the subluxation, the degree of the cataract hardness, whether there is a vitreous disturbance, and the strength of the intact zonules. So the two most difficult steps would be the rhexis and to stabilize the back to its normal central position. And I would just say two things that instrument are very useful. Like here, a microforceps is preferred rather than the conventional forceps. And we should use different ports. We should not hesitate to make multiple side ports in the cornea. So that is ergonomically very easy. And we can do it, as Muntakim showed very nicely, how to go under the iris. And with the proprioception and experience, we can do the rhexis under the iris. I will just fast forward as he has shown this one. One thing I would say that sometimes initiating the rhexis is very hard. Even making a puncture is tough. As Muntakim said that the rhexis should be started from the intact zonule area, but sometimes it's not possible. If the subluxation is towards the nasal side, we cannot start from that side because we can't take our instruments up to from the nasal side. And as there is no zonules, we can see that it's very hard to propagate the rhexis. In those sort of things, we have to give support. Muntakim showed that we can use capsular hooks or iris hooks to give support. But here, this is another method that we can give support with the Sinski hook or the dialer. And the rhexis can be completed. And this is a video of showing that I think this one was the capsular hook. I'm not going to show as Muntakim showed the capsular hook. I'll just skip this one. One thing I would like to say that CTR, when to implant it, whether CTR or CTS, because once this has been implanted, the cortex is trapped within the capsular bag and this segment. So it becomes very, very difficult to get this removed. You can see that the whole back complex with the CTR tends to come when we are trying to aspirate the cortex. So we can iatrogenically cause more damage to the zonules. So the notion is that we have to try to put it as late as possible, but as early as required. I'll just show a technique that what I do now is that once I have given a CTR, I'll just keep the surgical part. I hold it and then I drag it in the gap part of the CTR. There is a gap between the CTR, the circle. So I will drag that part within that area of the whole, and this is very easier. Stabilizing the bag. Dr. Muntakim has showed nicely that we can use capsular hook or iris hook. I would just make a point that when we are stabilizing it, we should use more than 2 or 3 hooks, so that if we use one, the pull is on the only one part and there is chances of tearing the anterior capsule. I'll just skip this part also. And one thing I want to say that if we have the technology, it is very useful in this sort of cases. Like in this case, there was a traumatic cataract. So I used the femtolaser assisted system of Alcon Lensex, and the hardest part, which is the rhexis in this sort of cases, we can easily do it. So beautiful rhexis is done. You can see that the whole anterior capsule came out, and the rest part, I think I'll just try to skip, as no similar sort of thing what Dr. Muntakim showed. This was a Sioni ring given. and we should always bury this knot, either make a scleral pocket or groove and then undermine it, or make a Hoffman pocket. Because we may do a very beautiful surgery, the lens is centered, but if we don't bury the knot, it can cause cyst. So one option is to make a Hoffman pocket. So making to clear corneal wound at the limbus and then creating a pocket on both sides. And then passing the needle over the conjunctiva and those scleral pocket that was made earlier on both the sides. And what we do is then we hook out the sutures through that pocket. So we bring both the sutures from both sides out of those pockets, and then we can tie that and put it in the groove. In this way, we don't have to do a peritomy or do a scleral pocket. The importance is that if we don't undermine it, we'll have a beautiful central lens, as we can see here, but we can see an iris cyst because the knots were not buried. So this is the end result that we want, central and in the back IOL. So the take home message would be that in back implantation should be our goal. Rexis is very crucial. We should have all bimanual irrigation aspiration if possible. This is puts less stress, and OVD before coming out, and we should have all the devices ready in our hand. So thank you all.
Thank you, Dr. Ishtiaq. That was some wonderful tips and videos that you showed on how to manage subluxation. We are running a little late, but we have so many questions that we will try to answer them shortly, try to wrap up within 10 to 15 minutes. So I would like to invite Dr. Mahabubur Rahman Chaudhry, sir, for the discussion session.
Yes,
Sir, if you allow me, can I say one of the questions and start it off?
Please go ahead.
The first question that came was that when we do SR biometry, SRKT, and then we do Barrett, we can see that there are some discrepancies. Then which power should I select, the SRKT one or the Barrett one?
Sir, you are not audible. Sir, you are not audible. Can you, I think. No, this is, yes. I think the microphone. Yes, we can hear you now.
So, anytime the Barrett formula takes a lot of things into consideration, so definitely we suggest that we should go for Barrett.
Thank you,
Yes,
sir. The next question was that for toric IOL, number one question that came was what should be the site for the main incision, and for beginners, can toric IOL be done with perivalvular block? So we have two questions for toric.
Yes, I would say that number one, we can definitely do by perivalvular, and there is no harm in that. Definitely we can. And what was the first question, Nazba?
What should be the site for the main incision for toric IOL?
This is a very important question. The site should be whatever site you are comfortable with, and don't change in the site for doing the toric IOL. Would Professor Jalal, do you have any comment on this, please? Do you unmute yourself, sir?
Thank you. Thank you, Mr. Chairman. There is no predilection. Any surgeon, wherever he gives his usual incision, he will give incision in that site. But during biometry, there is a place, your incision site, and that incision site should be marked in the biometry, making biometry. And if you enter the biometry that your incision is 10 degree, say in the left eye, your incision is 10 degree. In the right eye, your incision is 180 degree. You enter it in the formula that means in the left eye, for example, left eye 0 degree incision is very difficult for many surgeons. So if you give 10-degree incision, they will enter it in 10-degree, and the calculation will give you where your lens should be placed. This is very simple, nothing complicated.
Yes, that's very good. Yes.
Thank you. So we have the next question for EDOF lens. So there's this patient who wants to undergo clear lens exchange. She is 22 years old. So the question is to Mahbub sir that can this patient is a good candidate for EDOF lens?
Yes, this EDOF is a good option here, definitely, but it has to be bilateral because we want to get the best results, and the counseling should be done properly. So, and what are the limitations that we have to explain it to them? And that EDOF lens has a very good vision for distance and intermediate, but there are some complaint that the reading is difficult. So at times we tend to do a mypic shape in the non-dominant eye so that the results becomes better as far as reading is concerned. So EDOF is good and it should be bilateral, and we can, if she is not a very voracious reader, that is a very good option.
Thank you, sir. The next question is about those Morganian cataracts because they are always moving. So how to do the phaco procedure easily in those Morganian moving cataracts?
I would forward this to Professor Nazrul. Please, would you take this question?
Thank you very much. Actually, I talked in my presentation also that in the white cataract, some percentage you will get Morganian cataract. And unfortunately, this cataract is really hard and small. So in that cases, it is better to learn direct chop. You can hold the nucleus directly with the phaco tip and divide with your second instrument. That is the best way. But definitely it takes some learning curve. The first step you cannot do it. So in that cases, you try the divide and conquer. First divide and slowly make two divide and conquer, make 4 pieces, and slowly you can emulsify this. Number 1. Number 2, I showed another the scaffold technique. I find in many cases when there is no epinucleus, the whole posterior capsule is seen. The surgeon, the nucleus is 5+ hard. The surgeon become really puzzled what to do. So best way, you can put a scaffold by giving your IOL in the bag. It's better in the bag, and do your surgery very, very slowly and with many times viscoelastic, preferably visco, the dispersive viscoelastic, so that there is no harm to the endothelium. That is another way you can try the scaffold technique and the Morganian cataract. This 2 way, I think first is the divide and conquer, second is the direct chop, and third choice will be scaffold technique. Is my suggestion.
Thank you. Was there any other questions?
Sir. Yes. So the next question is about those hard rock cataracts. So what would be the preferred parameters for these type of cataracts?
Dr. Shaukat, would you take it?
Thank you, sir. Usually for scalping, you can use 180 to 200 for scalping. The aspiration should be like 28, 29. And for nuclear chopping, we can use 450 to 500 millimeter mercury, and power should be like 60% longitudinal or 70% longitudinal, and aspiration will be 32 to 35. That would be. Would you like to, Mahbub sir, would you like to add something?
I want to say one thing.
Yes,
sir, I just want to say one thing that during the hard cataract, I think I learned one thing from Mahbub sir, that he always takes a new tip when it's a hard cataract, and he writes this in his preoperative note. And his OT staffs are trained in such a way that today I was doing a hard cataract, and the staff said, "Do you want a new tip? This is a hard cataract," and it really makes a difference. Sometimes we don't change our tips for a long time; it gets pitted, and the sharpness is lost. So I would like a comment from Mahbub sir on this.
Yes, Ishtiaq, this is a wonderful tips, I would say. And this is, I close my eyes and during biometry and when I'm writing that this is about the heart cataract, that new teeth, make the eyeball soft, use Blu-rays. So these are the common things that we take into consideration while we are doing heart cataract. And as rightly pointed out by Dr. Shaukat, that the mental preparation, and this is a difficult case for even in experienced hand. But the question, going back to the question, so when it comes to sculpting is very important. So we use even 100% if required. The power should be that. But in that case, we know during sculpting, we don't need much vacuum. And the flow rate should be, if you use normally 20, it would be 22 or 25 in case of when we're sculpting the heart cataract. And most difficult is making it to two halves. Here we have to hold the nucleus very strongly, I mean very tightly. So we have to raise the vacuum. It can go to even 600, and the flow rate should be a little higher, maybe so that we can grab quite fast. And here the vacuum is very important. So we have to raise the vacuum. And at the same time, I raise the flow rate also so that this happens quite easily. And as far as the nucleus management for emulsification of each of the fragments, initially the vacuum should be high, around 500 millimeter mercury, and the flow rate should be around 25, and the power, depending on the density, it can be 60, 70, 80. But as we come to the last pieces, we lower the parameters, and if during the last two pieces we use viscoat, we use viscoelastic substance to push the posterior capsule behind and also coat the endothelium with the viscoelastic substance so that the endothelium is protected and the posterior capsule is protected. So these are the few tips for heart cataract, but you have done it wonderfully, and I really admire how the mentees has dealt with it, and it was an admiring presentation from all five of them, and especially with the theme. I think Zakia Wadu did the best, because personally she made a story out of it. In one case in 16, the same case, same patient in 19, in 2020. So, and it was really inspiring that how she motivated herself, and she went into doing the cataract, and she was very precise, just kept it to one surgery, and he gave the story so much inspiringly, so that I think a lot of people will be interested in doing it. And I thank other mentees also. You are no more than a mentee, you are mentor, and you have done a tremendous job, and hats off to you, and we are very proud of you. Any other question, Naziba?
Yes, we are almost at the end. So the last question is about, in case of subluxated cases, what is the nuclear management method? What is the method for phacosurgery that should be used? And number one is this, and the second one is that sometimes the capsular hooks are not available. So is it a problem to use those iris hooks for holding the rhexis?
Second question, I will forward it to the Muntakim Shahid, and this first one to Ishtiaq, please.
I thank Dr. Logan. He has been following us. He is a fellow of Bangladesh Eye Hospital and Institute. Thank you, Dr. Logan, for joining us from Malaysia. The preferred method is stop and chop or any other method, chopping method, because that holds part of the nucleus with high vacuum. And when we are separating, it does not put any extra pressure on the zonules, because in divide and conquer, as we separate, it puts some pressure on the posterior capsule as well as the zonule. So any sort of chopping method where we hold the nucleus with high vacuum and then separate with the other instrument, that method is preferred for this one.
Muntakim Shahid, would you?
Yes, sir, thank you, sir, for giving the opportunity. I can add one thing with the Ishtiaq, sir. One thing is saying in bag phacoemulsification in case of hard cataract. In case of soft cataract, if there is a capsular support is less, then you can pull into the entry chamber in the pupillary area. You can go for phaco. And the second question was whether we can use the iris hook for when we have not available the capsular tension hook. Yes, we can use the iris hook, but if you see sharply, the iris hook tip is sharp, but capsulation hook, the tip is blunt, and sometimes it is a point, it is a knob like thing. So if you use the iris hook, you can use, but very cautiously. If you pull very sharply, it can tear the capsule margin. So it is better to use the capsule attention hook for the subluxation cases.
Thank you. Majiba, over to you.
Thank you, sir. So these were the questions that came to us. So if there is no more addition by the panelists, then I will hand over to Dr. Mohammad Shaukat Kabir, sir, for the thank you note and to end the webinar.
Thank you, Dr. Mahajiba, for giving me the opportunity to thank all the. First of all, I like to thank all the mentees, Dr. Zakia Wadud, Dr. Ashraf, Dr. Shams Mahmood Noman, Dr. Muntakim Shahid, and Dr. Sarwat Rahman for wonderful presentation, and it was amazing. Actually, this concept was our scientific chairman, Dr. Mahbub sir, and that was excellent. And for that, I must congratulate all the mentees and mentors for their excellent presentation. I must also thank the chairman and of the scientific subcommittee, Dr. Mahbub Chaudhary, who is also my mentor. Here sitting two of my mentors, Professor Nozrul sir and Dr. Mahbub Chaudhary. Actually, I have learned FACO by seeing their FACOs in recording and tried myself, and sometimes they assisted, they suggest, and they always inspire me. Uh, for that, I must thank you them. I also give special thanks to all the speakers for making such a webinar very effective and practical one. I'd like to thank the mentors for their wonderful and teaching us all times. I also like to special thanks to Dr. Mahajiba and Dr. Ashraf for their tremendous effort for making this webinar effective and practical one. Thank you all, and I'd like to thank all the participants for joining us. Hopefully, we'll come with much more attractive webinar in the coming period. Thank you all.